Hi guys, I hope you're doing good. Yesterday I wasn't able to join the session because of personal reasons. I will be starting the session in a minute. Ask your friends to log in. All right, so I am starting the session as of now. All right, okay. All right, okay. So the first question we have for today is on physical examination, the patient exhibits subcostal retractions and grunting. Okay. Cardiac examination reveals a 2 by 6 holosystolic murmur. How do we find out that this grade of murmur is, severe or it is less severe? How? Anybody?
Like by this grading, like if it is low, so it would be a 2 by 6 or 3 by 6. If it is a high harsh murmur, it would be 4 or 5 by 6.
Very good. So anything beyond the three scale, 4, 5, or 6, that means it's a very severe murmur. It needs immediate attention. 1 and 2 are considered okay. All right. So if they say 1 by 6 or 2 by 6, then that's okay. That's non-significant. You don't have to worry about that in an adult person. All right, so this is a newborn, and that is why we will go through the question stem. But in an adult person, usually we don't care about if the murmur's intensity is 1 by 6, 2 by 6. If it is more than 3, then it's severely concerning. All right, so what's happening is that there's this newborn who was transferred to an ICU after 4 hours after delivery due to cyanosis. All right, the patient was delivered at 41 weeks gestation. Okay, pregnancy was uncomplicated. The patient's legs appeared dusky. Pulse oximetry shows 98% on the right hand and 83% on the left foot. What do you mean by there's a difference in the oxygen saturation? What do you think is going on?
COA.
Why
और
is
पार्ट कहते
Like in the quadcation of the aorta, we see some kind of difference in the bilateral circulation.
Mhm.
There's more on one side and less on the other side.
Okay,
There,
very good.
there, there may be a
Or
right to left,
okay.
maybe a right
Uh,
to left shunt.
all right. So there are subcostal retractions, grunting, 2 by 6 holosystolic murmur on the left lower sternal border. What do you mean by left lower sternal border? What type of murmurs do we see at left lower sternal border?
VSD.
VSD, what is tricuspid murmur? Why is my voice acting? Dr. Emma, okay, yeah, it's okay. In at the left lower sternal border, you either see VSD or you see tricuspid murmurs as well. All right. Femoral pulses are strong bilaterally. Which of the following is most likely cause of the newborn cyanosis? What do you think is happening? There is difference in oxygen saturation. The patient is cyanotic. He's unable to breathe. What's happening?
GSD.
Sorry, what?
There will be
GSD.
There's voice distortion. My voice is recording. Can you fix it? All right. Shoot again. Who wants to tell the answer?
Ventricular septal defect.
It is actually the quadcation of the aorta. So basically, there will be a right to left shunt via the ductus arteriosus, because of which we are also seeing different oxygen saturation.
Very easy. Again, there's this oxygen saturation difference that was very, very high yield in terms of USMLE step one. Whenever they say that the upper extremity has, increased oxygen saturation and lower extremities have lesser oxygen saturation, that means there's something they're talking about coarctation of aorta. What else happens in coarctation of aorta?
Collaterals also develop in the coarctation.
What else?
There will be lower extremity blood pressure difference, and there will multiple collaterals will be seen, and in coarctation there will be differential cyanosis also seen in the newborn.
Okay. So what is happening is that if you kind of see and you zoom it over here, preductal is greater than postductal, and that happens in two things. It either happens in persistent pulmonary hypertension, or it happens in coarctation of aorta. So this can give you a broad differential diagnosis. Okay, there's just something saturation oxygen differences going on in the upper extremities and in the lower extremities. So it can either be coarctation or it can be pulmonary persistent hypertension. The reason that it cannot be coarctation of aorta over here, why? Can anybody tell me why?
Murmur location.
Murmur location. Anybody else?
Cushions. Coarctation of the aorta is common
It
in
doesn't say any blood pressure.
Age of the patient, age.
the age. It's common in
Are also strong.
reform.
Okay. Anybody else?
What's your question?
We all missed out on this. We all missed out on this. If somebody wants to read this.
Like it's the pulse oximetry shows 98% in the right hand and 83% in the
In
left
upper
foot.
extremity, what happens in coarctation of aorta?
Lower extremities are affected.
Exactly.
Not the upper extremity.
Exactly. So we all missed this point. We all read this point wrong, and it was a collective mistake that we did. And that is that, the prime difference between persistent primary hypertension and coarctation of aorta is that in persistent primary hypertension, the preductal, or that is the upper body, saturation is higher than the postductal, or the lower body saturation. Why? Because there is right to left shunting going on in this, and that is why the baby was cyanotic. The baby was dusty, and he had difficulty in breathing, and that is why there was subpostural retractions and grunting going on. So in persistent pulmonary hypertension, what is happening? Upper extremity oxygen saturation is higher than the lower extremity. Whereas in coarctation of aorta, this scenario is reversed. Lower extremity oxygen saturation is higher than the upper extremity. And that is why I was asking again and again that what happens in coarctation of aorta? Can anybody tell me what's happening in a coarctation of aorta? Because we all missed out on this line. All right. So do not confuse coarctation with persistent pulmonary hypertension. It is not a step 1 level question. I don't know why they've included this in your. It's a step 2 level question. Usually they ask persistent pulmonary hypertension in terms of USMLE step 2. But that if they're asking that in step 1 right now, then that means they're making the exam tougher. So please try to get your basics right, guys. Okay. So if you kind of see it over here, and like I said, that one of the potential causes of persistent primary hypertension of the newborn, can anybody tell me what's the cause? Or why it happens?
No, ma'am.
It could be genetic, but I don't know that it's the most common cause genetic is.
Meconium aspiration.
So persistent pulmonary hypertension, it is a condition in which the pulmonary artery, the pressure, it remains elevated even after birth, and that causes right to left shunting of blood through the foramen valley and the ductus arteriosus. So not only ductus arteriosus, but also foramen ovale, there's right to left shunting going on. So it's a like a pathological condition that develops in people. Why is it developing? Can anybody tell me the specific cause of it?
Pulmonary hyperplasia.
Yeah, that can be one cause. What else?
Meconium aspiration.
Pneumonia.
Okay. What else?
Genetic mutation.
Perinatal asphyxia.
Meconium aspiration syndrome and respiratory distress syndrome are the two high yield causes of persistent pulmonary hypertension. Okay. So what I want you to remember from this question stem that persistent pulmonary hypertension can occur as a complication of meconium aspiration syndrome and respiratory distress. These two are the high yield causes of persistent pulmonary hypertension. Now, what is happening? The pulmonary artery pressure remains elevated, and that is why right to left shunting is happening via either the ductus arteriosus or the foramen ovale. All right. What is happening in persistent pulmonary hypertension? That the upper extremities have a higher oxygen saturation and the lower extremities have a lower oxygen saturation. This condition is reversed in the coarctation of aorta. In coarctation, the upper extremities will have a lower oxygen saturation and the lower extremity will have a higher oxygen saturation. Okay, so that is a difference. That is a prime difference over here. And like I said, right to left shunting occurs. It can cause a tricuspid regurgitation, and that is why I asked you guys that what other murmurs are there in the left lower sternal border. And I said that there are tricuspid murmurs as well. So it has a potential to cause tricuspid regurg. See, as I go down, it's mentioned over here. So it's meconium aspiration can be one cause. Lung hypoplasia can be the other cause. Lung hypoplasia can also occur in cases of respiratory distress syndrome as well. So, RDS, lung hypoplasia, and meconium aspiration are the two high yield causes of persistent pulmonary hypertension. Again, they will present as subcostal retraction and grunting. Coarctation of aorta doesn't present with subcostal retractions and grunting. Okay, so you see a difference over there. All right, so this is how it presents. Can anybody tell me how to treat the patient? How do you treat persistent pulmonary hypertension? You give supplemental oxygen, you can give mechanical ventilation, or sometimes you can give ECMO as well. All right. Okay, next question. We already wasted too much of time. Is the concept clear, guys? Is the concept of persistent pulmonary hypertension now clear?
Yes, ma'am.
All right. Okay. Next question. Blood pressure is 145/65 in the right arm. Okay. This is in the left arm. It's this. Pulse is 86. Respiration 12 minutes. She has localized tenderness to palpation in the left sternal border. Okay. There's something wrong with the left sternal border. Lungs are clear. Everything is clear. No peripheral edema. They're asking what is the cause of the patient's symptoms. Okay. So there's this woman who comes to the ED because of chest pain. She was moving furniture when she experienced sharp pain in the left side of the sternum that subsided quickly. Very easy. Since then, the patient has had episodic pain with deep inspiration or trunk movement. Again, very easy question. What do you think the answer is? Come on.
It's like a muscular pain.
Yeah.
Costochondritis.
Again, or anything. So costochondritis would seem the better option.
Very, very good. Again, very easy question in terms of that. If you're moving something and you have a muscle spasm going on, then that can mimic any sort of chest pain. If you see that there's localized tenderness to palpation, it is a very high yield for costochondritis. They like to throw it again and again if you want to help you differentiate any heart pathology with any muscle pathology. Okay, so they throw this that, oh, there's localized tenderness to palpation, because in terms of any heart pathology, you will not be having tenderness to palpation. All right, so that's one thing. If you kind of go through all of it, we talked about that coronary artery disease, how it can be presented. We talked a little bit about aortic dissection as well, how esophageal presents, and then there's this chest wall musculoskeletal pain. Again, it's worse with movement or change in position. So usually you don't advise the patient bed rest in that. You give NSAIDs to the patient and ask them to resume their daily activities. Okay, bed rest is the wrong answer on USMLE. You will never pick bed rest. Ask the patient to continue the normal activities and give NSAIDs. Okay. All right, next question. Okay, so coronary angiography reveals a ruptured atherosclerotic plaque with a thrombus in the left circumflex artery. All right, okay. What's happening? That causes near total occlusion. Normal endothelial cells surrounding the lesion have released large amounts of chemical substance that helps decrease the thrombus propagation by inhibiting platelet aggregation. Okay, which of the following substances was most likely secreted by these endothelial cells?
Like it would be the prostacyclin that would inhibit the aggregation, because the thromboxane A2 promotes aggregation and prostacyclin inhibits the aggregation.
Yeah. Okay, so prostacyclin. Again, very easy question in terms of that. All right. There are other people in the class too except him. Why is nobody else speaking today? Is everything okay, guys? Okay, so prostacyclin is synthesized from prostaglandin H2 by prostacyclin synthase. Again, once it's secreted, it inhibits platelet aggregation. If you kind of see this over here, if I'm kind of zooming it over here, this we all talked about. We all talked about the von Willebrand factor. What is GP1D, GP2B3A? Can anybody tell me what is the deficiency of GP1B syndrome called?
Was it Glanzmann's? No. What?
Othman.
I think Bernard Solé, something
Sorry,
like this.
Bernard Solier.
Bernard Solé, yeah.
Yeah, that's true. Bernard Soulier.
Yes.
Bernard Soulier.
Exactly. So loss of GP1B is Bernard Solier, and what about GP2B3A?
Glanzmann.
That's Glenman.
Glanzmann thrombus.
Glanzmann, very good. I always try to. Okay, what does von Willebrand factor help in? Does it help in platelet adherence or aggregation?
It brings the platelets together. The von Willebrand factor causes
Adherence.
two
Adherence. It's adherence.
It acts as like glue.
Here.
So von Willebrand factor acts as both. I told you guys this as well. That von Willebrand factor acts as adherence as well and aggregation as well. It takes part in both of the things. Okay. All right. Next question. All right. ECG reveals left atrial enlargement, and echocardiography shows a large pedunculated mass in the left atrium. What do you mean by this? What do you mean by
Cardiac myxoma.
Atrial myxoma.
Cardiac
myxoma?
myxoma.
Very good. Atrial myxoma. Very good. What is the myxoma made of?
Myxomatous tissue.
What is the answer?
Mucopolysaccharides.
polysaccharides.
The scattered cells within mucopolysaccharides trauma.
Very good. So again, you saw the last line. You said, okay, myxoma is made of this. Boom, answer. All right. You don't have to. You see, that is why I always vouch on you guys reading the last lines, because answer is within the last lines. But for completeness sake, if you think that there's something you cannot figure it out from the answer stem, then also try to go back and read the question. But over here, we didn't need to read through the question again, so we directly put the answer. All right. Next question. In some patients, certain medications can cause a redistribution of blood flow away from the ischemic areas, exacerbating existing myocardial ischemia. All right. Which of the following drug effects is most likely to produce this phenomenon? What are these? What are they talking about?
They're talking about the coronary steal syndrome, basically. They're talking about the coronary steal syndrome, in which, when you give there's some kind of letters like the diparademol or anything, it would cause the coronary arterial dilation, and it will make decrease the blood reaching to the ischemic areas. It will take blood to the actually more profused areas. So they are causing this coronary arterial dilation.
All right. We all agree with them. Yes. All right.
Yes.
Okay. So increases in resting blood flow to ischemic myocardium, we know that they are primarily mediated by adenosine and nitric oxide that trigger coronary artery vasodilation. All right. Pharmacological arterial vasodilators like adenosine, diapridamol, they mimic the vasodilation that occurs with exercise and may cause redistribution of blood flow from ischemic to non-ischemic areas of the myocardium, and that is what you mean by coronary steal. All right, there is other steal that we also talked about. What is that other steal?
Subclavian
Subclavian steal. Very good. What are those three? What are the three things? Three symptoms happening in subclavian steal. Come on, guys, I told you this.
Exercise intolerance, meaning the
Yes,
dizziness and
dizziness. Very good. Vertigo. Very good. Pain in
vertigo.
the
Yeah,
arm.
And
Very
the blood
good.
pressure difference.
Blood pressure difference.
yeah, blood
Very
pressure
good.
difference.
Again, I told you guys what's going to happen. The blood is not going to reach to the basilar artery in the brain, and that is why, the patient was experiencing syncope and dizziness because the blood was redirected towards the other thing, and it wasn't going to the basilar artery. So, very high yield for the symptoms are very high yield. They won't ask you about the treatment and diagnosis. They just want you to diagnose it. All right. Fetal heart tones are normal. That is traced bilateral fetal edema to the shins. Physical examination is otherwise unremarkable compared to a non-pregnant state. Which of the following cardiac changes are most likely found in the patient? So they're asking if this patient is pregnant. What will be the changes be in a pregnant patient? Come on, we know this. It's going to increase.
Increase preload.
Preload is going to
Increase cardiac output.
Cardiac preload decrease and it decreases
And increase the
afterload.
afterload. Yeah.
Afterload will decrease. Yeah.
Yeah, afterload will decrease because they go opposite. Most of the times, the afterload represents the resistance, right? So the resistance will decrease. If you kind of see it over here, this chart is very high yield. It's also present in your first aid market, double market, because they love to ask this question on step one. So, market, again, your blood pressure will decrease, heart rate will increase. In terms of respiratory, your tidal volume will increase, FRC will decrease. Plasma volume is, of course, increasing because there's more blood now added to the system. And SVR will decrease because I told you guys that SVR and cardiac output go opposite. Most of the times they go opposite. All right, what's this? Very easy. What happened
Hypertrophy.
Concentric
Concentric hypertrophy.
Yeah, concentric.
Yeah.
hypertrophy? Okay. Chest X-ray is consistent with pulmonary edema. Rapid, ECG shows AFib. The patient dies despite appropriate medical care. Autopsy is performed and gross examination of the heart is shown. There are bilateral crackles and heart, which are heard in the lung auscultation. A histological examination of the myocardial reveals thick myocardial fibers with large hyperchromatic nuclei. What do you think the answer is? Come on, very easy.
Hypertensive heart disease.
Hypertrophic cardiomyopathy.
B.
C.
We all agree with C?
Yes, it's the B. It's the hypertensive heart disease.
Very good. Okay. Again, there's concentric left ventricular hypertrophy. If the chambers were, if the cavity size was increased, then they must be talking about dilated cardiomyopathy. Okay. And all right. How do you differentiate hypertrophic obstructive cardiomyopathy along with aortic stenosis? Because those murmurs literally sound the same. How will you differentiate? I told you guys this.
The hypertrophic one would have an ST apart from
In
On the
aortic
basis
is hyper,
no,
hypertrophy and in cardiomyopathy is concentric.
no. On the basis of pulse.
The hypertrophic cardiomyopathy will be asymmetric.
eccentric.
No.
Eccentric.
In aortic stenosis, so what I'm asking is that aortic stenosis and hypertrophic obstructive cardiomyopathy have the typical same murmur, because aortic stenosis and hypertension, they are the two most important causes of hypertrophic cardiomyopathy as well in old age patients. So what I want you to know from this is that aortic stenosis murmurs and hypertrophic obstructive cardiomyopathy murmurs can sound the same. The way you can differentiate them is based upon the pulse. So the pulse is delayed in aortic stenosis. Okay, it is weakened, it's delayed, but in hypertrophic cardiomyopathy, the pulse rate is normal. Okay, so you can differentiate on the basis of pulse, and pulse is the right answer on USMLE. Okay, is it clear, guys?
Yes.
Yes, ma'am.
Yes.
All right. Okay, temperature is 37, blood pressure is 98/56. Complete physical examination ECG shows no abnormalities. Which of the following is most likely mechanism of the patient's syncope? So what has happened? 24-year-old patient, he ran a half marathon, and there are no chest pains, nothing has happened. There's no history of sudden death. What's happened? Why did he faint?
Because of the decreased venous return, like the decreased preload, because when athletes are like running hard, and if they suddenly stop, so the blood is not returned to the heart at the same like frequency. So that's why they have a sort of syncope or something like that. So there was decreased venous return, the decreased preload.
Exactly. And that is why we always ask the athletes to, hydrate themselves throughout. And the reason is that, so that their cardiac preload, gets adjusted, and so that they don't faint. Otherwise, if there's decreased cardiac preload, then of course they're going to faint. Over here, you can see that the management is to give oral hydration. Again, there's decrease in venous return, and for that, it is advised that the athletes, number one, they hydrate themselves throughout the marathon, and the other is they avoid salty drinks. So if somebody is drinking any salty drink, or Gatorade or something like that that has a high salt concentration, then we don't want them drinking that before the start of the marathon. They can drink it post marathon, but not the start of the marathon, because that can kind of expedite their collapse as well. So two things: one, advise them to drink water throughout, and second, do not drink salty drinks before the marathon. All right. Okay. Next question. A chest radiograph reveals clear lungs and normal cardiac silhouette, but a narrowed mediastinal shadow. Okay. Which of the following is most likely cause of cyanosis in the patient? All right. So there's this newborn evaluated for cyanosis immediately after birth. On examination, the patient's oxygen saturation is 70% in all four extremities and does not change despite 100% oxygen saturation. There are no heart murmurs going on. Peripheral pulses are normal. What's happening?
It's the TGA, the transposition of great arteries. So
Very
parallel
good.
pulmonary and systemic circuits are created, like the deoxygenated blood is not getting oxygenated, and more oxygenated blood is still going to the lungs to get even more. So that's why the oxygen we are giving him, it's not improving his saturation. So they are
Very good.
totally complete circuits.
Very good. All right. Yeah. So transposition in the great aorta most commonly occurs in diabetes mellitus moms as well. TGA, ventricular septal defects, are the two most highest complications of diabetes mellitus mothers. And these are non-compatible with life. A TGA is non-compatible with life, and that is why you have to have a patent foramen ovale in these patients. Surgery is done to create any sort of shunting, so that the blood gets shunted, and the patient doesn't die. And it's severely fatal, and that is why you either give prostaglandin infusion, because it maintains the patent ductus arteriosus, or you just do this surgical procedure which is called atrial septostomy that maintains the patent foramen ovale. And eggs on a string eggs on a string can be seen on the chest x-ray. You can see a narrow mediastinum as well. Very high yield in terms of that. You need to do echo Murmurs are not heard because there is no shunting going on currently, and that is why murmurs aren't heard. And again, in which patients TGA usually occurs? In diabetes mellitus moms. Okay. All right. Next question. There is no appreciable murmur on auscultation of the anterior chest. Distal pulses in the radial arteries are prominent. Dorsalis pedis with posterior tibial pulses are difficult to palpate. Okay. Rest of the physical examination is unremarkable, which the following is most likely causing the patient's murmur. So the blood pressure is 170. Okay, S2 is physiologically split, S1 is present, and S4 is also heard, and as well as a continuous murmur auscultated with the back at the left interscapular area. So there is this guy who comes because, leg cramps. Why do you think that's the cause? Why is leg cramping occurring in this patient?
So again, he's having a percussion of the aorta.
Very
Question
good.
of aorta.
Yeah, regurgitation of aorta.
So
Yeah.
he's getting again the extremities affected, and the things we are that's like seeing on it is because of the blood is flowing through the collateral blood vessels.
Yeah, very good. Okay. So what is the answer?
It's B.
And B is the increased blood flow through collateral blood.
Very good. Again, so the patient was having, leg cramps again, which means his legs were hypoxic or, his legs had fatigue. If you see that the blood pressure was 170 bilaterally in the upper extremities, which means, there was hypertension going on. So I think, hypertension going on in the upper extreme. Oh, so what? Oh, I think I understand what you must have been confused with. So in coarctation, the blood pressure of the upper extremities is higher than the lower extremities, but remember the oxygen saturation is opposite. Okay. So I think you might have gotten confused with the increased BP, so you thought that it's greater oxygen saturation in the upper extremities. So over here, blood pressure is high in the upper extremities. In the lower extremities, there are weak pulses in the lower extremities. Again, neonates are kind of different from that. And then it can be associated with Turner syndrome and bicuspid aortic valve, two most important high yield associations in terms of USMLE. So, yeah, okay. Next question. All right, okay. Physical examination shows a well-appearing child. The lungs are clear to auscultation. Cardiac auscultation findings at the left lower sternal border are below. Okay, so what type of murmur can you hear at the left lower sternal border?
Tricuspid and VST.
Very good. Tricuspid and VST. Which of the following is the most likely the diagnosis? So we can't see tricuspid over here. We only see one. What do you think the answer is?
Like it is the VSD, but on the media, it's difficult to pick as a
Yeah.
junior through.
So that is why I said that, on the media, I never picked up any heart murmur. And the reason that because I couldn't able to, I only did that, by reading the WICNet, but by hearing it, I was unable to differentiate between the murmurs. So try to use your common sense, and that is why I say that USMLE wants you to pass, but you have to use your brain for that. Again, we know that at the left lower sternal border, there can be only two murmurs, either tricuspid or VSD. We don't see, Holcomb's location is a little bit higher than the VSD. Atrial septal defect, no place. Aortic stenosis, no place. Aortic regurgitation, no place. PDA has a continuous murmur. They did not talk about that. Otherwise, they would have mentioned it. And plus, PDAs are usually very evident when a child is born. This patient is 11-year-old boy. So it can only be VSD because it was also coinciding with the location they gave us. All right. The other thing they gave us was this intensifies the hand grip exercise, and that is why I told you guys that these maneuvers are really, really high yield. You need to memorize them. As much you hate them, you have to memorize them because USMLE loves asking maneuvers and the responses, and then what if they increase and if they decrease, what's going to happen? They love to ask you about that. So try to memorize that. All right. Next question. Okay. What's happening? There's also a small patent Foramen ovale and a small patent ductus arteriosus. Definitive surgical correction of the main congenital abnormality is planned. Pending definitive repair, which of the following temporary measures would most likely improve the patient's condition? All right. So a full-term newborn is, evaluated because of mild tachypnea and cyanosis, and it could reveal transposition of the great arteries. I told you guys this. What do we do in transposition of the great arteries?
Like we have to make big we'll make the
Make
patent
the
for big.
patent ductus
PDA.
open.
So what do you think the answer is?
D.
Even oxygen.
D, I think enlarging the path.
That's what I even said in the previous algorithm, that either patent foramen ovale needs to be kept open, or patent ductus arteriosus needs to be kept open, because we need some sort of shunting, so that the blood mixes and distributes throughout the body. Otherwise, it's extremely fatal. The child dies without this intervention. Okay. Next question. The pathologist concludes that the infant likely died of a sudden infant death syndrome. Okay, what is the most common cause of sudden infant death syndrome? Can anybody tell me that? Anybody?
It's hypertrophic cardiomyopathy.
No, the most common cause of sudden infant death syndrome is positioning. So if the baby is lying upside down and he remains upside down for a very long time, then he will suffocate. All right. So the most common cause of sudden infant death syndrome on USMLE is positioning. Okay, you need to remember that. So the autopsy also shows an incidental finding of bicuspid aortic valve. If the patient survived, he would have been at the greatest risk for what?
Like this would be the aortic stenosis in his 50s, because normally it occurs after 50. But if we have bicuspid aortic valve, so in 50s.
Yeah, exactly. So we know that bicuspid aortic valves have, accelerated atherosclerosis. That is something I want you to remember in terms of that. There is another condition which also has premature atherosclerosis, and that is what? Can anybody tell me?
Aortic dissection.
No. Premature atherosclerosis is
cholesterol.
Premature atherosclerosis is also a very distinct feature of systemic lupus erythematosus, SLE. Okay, it is an exam question. They love to ask this, that SLE, it also has premature atherosclerosis, and the most common cause of death in SLE used to be, kidney complications, but now because of the recent novel treatments, the kidney complications have gone way down. So now people are dying of accelerated atherosclerosis in SLE. That is now the most common cause of death in SLE. Okay, so that is what also happens in bicuspid aortic valves. And if you kind of go down and you see that aortic stenosis, again, it's a common complication of bicuspid aortic valves. We talked about that previously as well. Again, usually they kind of have it around the age of 50, and the patient becomes symptomatic greater than 65 of age. Okay, next question. All right. Ophthalmology examination shows bilateral papilledema. The lungs are clear to auscultation. Cardiac examination reveals an S4. Laboratory results are as follows. So today, they're 23%. Platelets are down. BU and creatinine are up, and their numeral schistocytes. What's happening? So the platelets are down. The creatinine is up. There are schistocytes going on. What's happening?
So the kidney vessels are
Microangiopathic
getting
hemolytic anemia.
Chronic kidney disease.
Kidney disease is because of the hypertension, his kidneys are suffering. So there will be necrosis of
Microangiopathic hemolytic anemia.
So if you kind of read the question from above, wait, okay. So he's having after he's brought to the ED after onset of severe headache, nausea, vomiting, and confusion. And he was in CKD. He has been prescribed 2 antihypertensives, but he has been non-compliant. Okay, non-compliant is a very big word. So he is having some severe CKD. So in chronic kidney disease, you also see schistocytes in long term. That's also something that's attached to it. And the blood pressure is really high. Again, you see bilateral papillary edema. Why are you seeing bilateral papillary edema? Can anybody tell me?
High blood pressure.
And
High blood pressure.
Hypertension.
Hypertensive emergency.
Very good. All right. So, which of the following pathological changes? He clearly said that he's been non-compliant with therapy. So, long-term hypertension, what is it gonna cause?
Renal failure.
It will cause the fibrinolysis.
Non-compliant.
The renal necrosis of a smaller.
Yeah. So it was in hypertensive emergency. Why was it in hypertensive emergency? Because the blood pressure exceeded 180. Can anybody tell me the difference between hypertensive urgency and hypertensive emergency? What are the cutoffs we use?
No organ damage.
End organ damage.
Hypertensive emergency is associated with organ damage.
Very good.
Yeah, and not
So whenever
urgency, not.
Okay, very good. So there are no strict cutoffs between emergency and urgency. It is we see that if there is any end organ damage going on, if the kidneys are compromised, the eyes are compromised, or if any other things are compromised within the body, then that is usually hypertensive emergency. So if the patient is having hypertensive emergency, the reason why, because he was non-compliant with the antihypertensive that we gave him, and chronically, if there is if the kidneys are already malfunctioning because the patient was already a chronic kidney disease patient and there is now exceedingly high hypertension going on, so that in long term is going to cause fibrinoid necrosis, or it can also be a precursor of that. All right. And if you kind of see that they triggered microangiopathic hemolytic anemia, so somebody said that it was microangiopathic hemolytic anemia, you were right. It triggered the cause. The platelets got low. There was peripheral smear showing numerous cystocytes. I'm sorry. And there was the creatinine was also really high. Again, how do you differentiate microangiopathic hemolytic anemia from hemolytic uremic syndrome and thrombotic thrombocytopenic UP, or TTP? How do you differentiate it?
For TTP,
Yeah.
there is psychiatry involvement. There is usually present with like 5 signs, apart from thrombocytopenia, renal damage, and there is in addition there is fever and there is neuropsychiatry involvement compared to HUS.
Okay, yeah. Again, neurological manifestations are important. If you see neurological manifestation along with fever, most likely they're referring to TTP. If there are only kidney problems going on, then it can be hemolytic. But if you have kidney and neuro both, then most likely they're referring to TTP. Okay. All right. Next question. The right lower extremity is significantly larger in diameter than the left. Of course, edema is present. The skin overlying the involved area is thickened and dry. What do you mean by this? So there's edematous leg and the skin is thickened and dry. Is it a sign of arterial insufficiency or venous insufficiency?
It's like
Arterial.
Lymphatic flow is blocked.
Lymphedema.
lymphatic flow is blocked.
No, I'm asking thickened and dry.
Arterial insufficiency.
It's venous. It's venous.
Insufficiency.
Venous. Very good. Very good. So, again, in venous insufficiency, you will also see that the area will be thickened and dry, but because there's edematous leg present, which means that the lymphatic drainage is compromised. Treatment of the patient's symptoms should include which of the following strategies? What do you do?
Compressing that to increase the flow. We will do the compression because it's lymphedema.
Yeah. You're right. Again, so this is lymphedema going on. There's a swelling, heaviness, discomfort. Most commonly, lymphedema occurs in, if there's any malignant obstruction, if, there's, radiation given to the patient, or even sometimes lymphedema can occur in bedridden patients and old bedridden patients. And that is why there's this thing called as compression stockings and limb elevation. You can see it's over here, compression stockings. So compression stockings are, already applied on the patient as a prophylaxis so that they don't develop lymphedema long term. That is something, done after post-surgery patients. If they're really overweight, if they cannot mobilize much after the surgery as well, then, compression stockings are, given to them so that they can wear them post-surgery so that they don't develop lymphedema. Okay. So it can also be done as a prophylaxis as well. Diuretics are also contraindicated over here. All right, next question. Initial adverse scores are 5 and 7 at 1 and 5 minutes after birth, respectively. The neonate slips fingers and toes appear cyanotic. The patient should be immediately treated with a medication producing which of the following effects. All right, so there's this 1-hour-old neonate with prenatally diagnosed tetralogy of Fallot, and he was admitted to the NICU with cyanosis. All right, so what's happening?
Like again, we will have to maintain the patency of the ductus arteriosus so that because he has already tough.
Yeah.
Exactly. So again, whenever the patient is severely cyanotic and you have to maintain the patency of either the ductus arteriosus or the foramen ovale so that the shunting happens and the cyanosis reverses. Over here, you can see that the right heart obstruction, left heart obstruction, and then there's this parallel circulation that's happening in transposition of the great aortas. All right, okay. Next question. All right. ECG shows sinus bradycardia and STEMI in the leads 2, 3, and AVF. What type of MI is this?
Inferior wall infarction, right coronary artery.
Right
Very
coronary.
good. Inferior wall MI, very good. Occlusion of which of the following? Of course, we talked about this. So, yeah. All right. Okay. Next question. Serum creatinine level is normal, valsartan, and hydrochlorothiazide are prescribed. What is the mechanism of action of valsartan?
Angiotensin
It is the
receptor
angiotensin
blocker.
receptor blocker,
ARB.
direct receptor blocker.
Okay. What is the adverse effect of valsartan?
It
Edema?
decreases the preload
Yes.
and afterload.
Edema, I think so.
No, it decreases afterload.
Can anybody tell me?
Fluid retention, I think.
No.
Dizziness.
Yeah, dizziness. That's one of it. Very good. Again, so you use valsartans when the patient has certain contraindications to ACE inhibitors. Then only if they have angioedema or they have problems going on due to increased bradykinin. So you switch the patient from ACE inhibitors to ARBs, that is valsartans. What do you mean by hydrochlorothiazide? What are they used for?
The first line therapy for the high blood pressure.
Blood pressure. Very
There's
good.
some
First line.
heart channels.
Very good. Okay. All right. So blood pressure and plasma renin activity at baseline before starting treatment after 3 weeks of therapy are as follows. So this is the baseline. And after 3 weeks, there is no significant decrease. Plasma renin is also okay. Which of the following best explains the findings of the patient? What's happening?
Like this is the medication.
Medication non-adherence. Yeah.
Very good. Again, so if you give the patient, two antihypertensives, and if they're taking it, then there is a significant drop in blood pressure. But if there is no significant drop, then it means that it's just medication non-adherence. It could have been renal artery stenosis if the creatinine levels rise. All right. But again, in valsartan, it does not happen. It's most likely a trait for ACE inhibitors, that if you give ACE inhibitors and the creatinine levels rise, then that means that the patient has bilateral renal artery stenosis, and that is why they're contraindicated and you use valsartans. But again, in valsartans, it does not happen. All right. Last two more questions, and then we will be done for today. All right. BMI is 27. Physical examination shows no abnormalities. Okay. Is anything wrong in the labs?
Parathyroid is decreased and calcium is high.
Calcium is high.
Okay. All right. He has a history of hypertension. He has been treated with pharmacological therapy, weight loss and dietary salt restriction. Blood pressure is okay. Pulse is okay. All right. Which of the following is most likely responsible for these findings? What's happening?
Medication effects.
Medication effect.
Very good. So we can see that over here that he is on, pharmacological therapy. And what pharmacological therapy causes an increase in calcium?
Thiazide
Thiazide.
Thiazide diuretics,
Very
hydrochlorothiazide.
good. So there is this adverse effect for thiazide, hypergluc, hyperglucose, and then there's hyperlipidemia, hyperuricemia, and hypercalcemia. All right. What does it do to the potassium?
Decrease.
Decrease. Very good. What increases the potassium?
Potassium sparing diuretics, spironolactone and eplerenone.
potassium sparing diuretics.
Very good. So this was a TZD, and again, it was an adverse effect of that. All right. Okay, how do you differentiate familial hypocalciuric hypercalcemia with hyperparathyroidism? How do you do that? Oh, it's, I think, beyond your level. You do that on the basis of urinary calcium, but I think it's just beyond your level, so I'm not going to ask any more question regarding that. All right. The patient has been seen frequently in the clinic and has had no cyanosis, respiratory distress, or difficulty feeding. The parents become concerned when their son's surgical plan is discussed because he does not have the clinical signs demonstrated by other children with tetralogy of Fallot. Which of the following, again, I told you guys this. What is the greatest determinant of symptom severity? We talked about this.
Right ventricular outflow tract
Outflow
obstruction.
tract obstruction, yes.
Pulmonary
Very good. We
stenosis.
talked about this. Pulmonary
Yes,
stenosis, we
yes.
talked about that. So if you can kind of see over here, we also talked about that the pulmonary and fundibular stenosis degree is, the most dangerous thing within the tetralogy of Fallot. And with that, we are done for today. I think it will be Dr. Moss. Has Dr. Moss joined us? I think Dr. Moss, are you here? Let me ask him. All right, guys. Do you have any questions for me? Do you need to ask something? How is your step 1 prep going on?
It's good.
It's going good. Do you guys need help with anything? Do you guys have feedback?
Yes, the classes are going good. The preparation is also smooth.
Very
Okay.
good. When do you guys plan to take step 1? By what time?
I'm planning yet.
Soon? You guys are planning. They have made step 1 a little harder, but don't worry. We're here for you. We always try to teach you high yield stuff and try to do, passive revision and again at NextGen USMLE. Our mentors work tirelessly for you guys, me, Dr. Ahmad, Dr. Moaz, all of us. But yeah, they have made step 1 a little harder. I was going through the Q bank and I was like, 2 years ago, this wasn't this hard. They've made it, harder for students. Of course, it's going to be more competitive. The more years we are going to advance, they're going to make it more competitive. But again, everything is doable. That's what, like, maybe 10 years ago, our generation would have, found those questions easier what 10 years ago people passed. And so I think it just, generation to generation difference. But yeah, I think you guys we will be able to do it. Don't worry. Just keep on revising first aid, pathoma. Never let go of that. Solve as many questions as you can. Keep on revising through path of learning. The more you engage in discussions, the more you talk about it, the more it's going to stick into your memory. And is Dr. Ahmed over here? Dr. Ahmed, are you here? Where are they? I think it's.
I think, ma'am, we'll just wait if Dr. Moss connects on the same link. Otherwise, they will send a new link.
Or okay, guys, so I finished talking with Dr. Moaz. He's going to be joining us within 1 to 2 minutes. Please stay on this session. I wish you guys happy learning. If you have any further questions, reach out to Dr. Hamza and he will get back to me. Have a great day. And I'll see you guys tomorrow.
Okay, thank you.
Thank you.
Thank you.
Hmm.
Mukhtar. 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 Mukhtar.
طلبت لا يمكن الاتصال به الآن. نرجو معاودة الاتصال لاحقا.
Hello everyone. Can all of you hear me?
Yes.
Yes.
Yes. Just let me share my screen.
Guys, please mute the mic if you are not talking. Felix and all.
Hello guys, can you hear me now?
Yes.
Yes.
Okay. Okay guys, so today we are gonna start the complications of myocardial infarction, right? So whenever you are having myocardial infarction, you are going to have some complications, right? So what are those complications and why are they important? Because whenever USMLEs and NBMEs are going to give you questions, they're going to give you these complications, and then they're going to give you a timeline, and then they're going to ask you what is this complication, right? So what is the most likely diagnosis? So these complications become very important, and they are very important for your exams, and they come in step 1, step 2, and step 3 as well, right? So first of all, the most common complication is that cardiac arrhythmias, right? So the number one thing that you want to remember is cardiac arrhythmias, right? So whenever you are having myocardial infarction, the number one thing that you guys, just give me 1 second. So you Okay. Okay, guys. So the number one complication is cardiac arrhythmias. And which cardiac arrhythmia? So the most common cardiac arrhythmia is the ventricular fibrillation, right? So most common one is the ventricular fibrillation. So whenever a patient of myocardial infarction comes to you and he dies during the first 48 hours, right? So the first common cause of death during the first 48 hours of myocardial infarction is going to be cardiac arrhythmias, right? So keep this thing in your mind, right? Now, after that, we have a thing which is known as the acute pericarditis, right? So, first of all, we are going to go into the details about what is an acute pericarditis, right? So, basically, acute pericarditis means heart has three layers, right? So, there is endocardium, there is myocardium, and then there is epicardium. And outside the epicardium, there is pericardium as well, right? So, pericardium is the outermost layer of the heart. And yeah, yeah.
Doctor, excuse me, your screen is too small. It shows too small for us.
I think it's in
So,
mobile phone.
yeah, speak to- Guys, yes. So I was telling you about acute pericarditis, right? So acute pericarditis basically means the inflammation of the pericardium. Now there could be a lot of reasons for acute pericarditis, right? So it could be due to viral infections, it could be due to some kind of a malignancy, it could be due to chronic kidney disease, and we are going to study all of those things, right? So acute pericarditis could be due to a lot of reasons, right? But whenever you are having a heart attack, during the first 3 days, right? So especially during the 1 to 3 days, acute pericarditis occurs because there is neutrophils. So there are neutrophils that are present on the necrosed myocardium. So whenever there is a myocardial infarction, there is necrosis of the myocardium. And in that necrosed myocardium, there will be neutrophils, right? And those neutrophils are going to attack the pericardium. And then there will be acute pericarditis. Now, so the second most common thing is how does the acute pericarditis presents to you, right? So till now, we have discovered different causes of chest pain. The number one was thoracic aortic aneurysms, right? So if you see the thoracic aortic aneurysms, you can see that in case of thoracic aortic aneurysms, there is a dull chest pain that will be going on for lots of amount of time. So for like 1 month or 2 months, and then there will be mediastinal compression symptoms as well, right? So those patients are gonna have dysphagia. Patients are gonna have hoarseness of the voice as well. Then the second cause of chest pain was aortic dissection, right? So in aortic dissection, we got a chest pain, and that chest pain was radiating to the back, right? And then there was difference of blood pressures between the two arms. Now, the third cause of the chest pain that we studied was myocardial infarction, right? So, in the case of myocardial infarction, the thing that occurred was that there was chest pain, and that chest pain was radiating to the left arm. That chest pain was going to the jaw. That chest pain was going to yes, and then there was diaphoresis, nausea, sweating, tachycardia, all of those symptoms as well. So that was myocardial infarction. Now, after doing all of these things, now we are coming to the fourth cause, which is the acute pericarditis. And regarding acute pericarditis has a pain which radiates to the back. But the most important feature of acute pericarditis pain is that this pain is relieved when the patient leans forward. Right now, they could give you this thing in a lot of different ways. So they can say when the patient is lying down, the pain is worse, and when the patient stands up or when the patient sits to eat something, the pain is better. Or when the patient inspirates, the pain is getting worse, and when the patient does not inspire it, the pain is getting better. And then there would be friction rub as well. So, and then there would be friction rub as well that would be present on auscultation. And the last thing that will be present is that ECG is going to have ST segment elevations in all the leads. Now, what do I mean by all the leads? So, normally, if you see a myocardial infarction, the ECG elevations would be maybe in V1, V2, V3, or V4, or the ECG changes would be in V5, V6, 1 AVL, and these are different set of leads, right? And one ECG change could be in 2, 3 AVF, right? So these are different kinds of lead, and only one group of lead is going to be affected in myocardial infarction. Now, what if on ECG two different groups of leads are affected, right? So if the ECG has ST segment elevations in V1, V2 as well, and the ECG has ST segment elevations in V2, 3 AVF as well, then it means that this patient is having a condition which is known as acute pericarditis, right? And then there would be frictional rub as well, right? Now, the second thing is that this condition is known as the post-infarction. So if this pericarditis occurs within the first 3 days, this condition is known as the post-infarction membranous pericarditis, right? And this condition is usually self-limited. But sometimes they could ask you, what could you do for the treatment of this condition? So what could you do is that you could give the patient aspirin, right? You cannot give NSAIDs to this patient. You cannot give NSAIDs to a patient who is having heart attack, right? The normal treatment for acute pericarditis is NSAIDs plus colchicine. But you cannot give both of these drugs to a patient who is having acute pericarditis. Why? Because if you give both of these drugs to this patient of post-infarction fibrinous pericarditis, the heart vessel is very weak and the heart walls are very weak. So if you give these patients NSAIDs, these patients will have their heart bursted or they are going to have a rupture of their heart, and that is going to cause a lot of problems, right? Now, after post-infarction fibrin, so does anyone has any question? Is anyone having any questions till now?
Yes, I have one question. Dr. Moaz, you said we cannot give uh as we can give aspirin but not NSAIDs. Is aspirin not an NSAID?
Okay, guys. So one important thing. My screen would get better. I'm having some technical issues. I would fix my screen in some seconds. Now, second thing is that so the mechanism of action of NSAID so and aspirin is very similar, right? But they are different in some ways as well. Why? Because aspirin belongs to the salicylic acids of compound, right? So aspirin belongs to the salicylic acid groups, right? Whereas the NSAIDs did belong to some other groups as well. So they usually belong to the coxibs and other families, right? So their structure is very different, right? And secondly, NSAIDs are irreversible. Right? Secondly, NSAIDs are reversible. Why does this become important? So maybe I would share the pathway with you. So whenever you give a patient aspirin, right, their platelet formation is reduced, right? So whenever you give a patient aspirin, the patient's platelet formation is reduced. Now, why is platelet formation so important in heart attack? So if you remember the atherosclerosis topic, I told you guys that if if whenever atherosclerosis is happening, there is smooth muscle proliferation, and that smooth muscle proliferation is due to platelet derived growth factor, right? So if you limit the platelet formation, the patient is gonna have no more clotting, and that would be beneficial. So that is why we can give aspirin in case of acute peric. So that in case of correct, give any. Just give me a second.
Dr. Moaz, your voice is breaking constantly.
Okay, guys, I'm back. And let me share my screen now. Yes. So we were discussing acute pericarditis, right? So I told you that why do we give aspirin in case of, yes, so I was switching my device, right? Okay. So I was telling you guys why do we give aspirin in case of acute pericarditis, especially in case of post-infarction fibrinous pericarditis, right? So now the next thing is papillary muscle rupture. Now we have two things here, and both of these things are important. Okay. Now the first thing is papillary muscle rupture. Now both of these things are gonna happen between the 3 and 14 days, right? So if a patient is having a problem in 3 and 14 days, you can just imagine three things. One is papillary muscle rupture, the second is intraventricular septal rupture, and the third is ventricular free wall rupture. Now we are gonna go into the detail of all of those things, right? So first of all, what is papillary muscle, right? So if you look at the heart, we are gonna see that in case of heart, papillary muscles. Papillary muscles are the structures which hold the mitral valves in place, right? So papillary muscles are the structures which are gonna hold the mitral valves in place, right? So if a papillary, so now what is happening is that we have a posteromedial papillary muscle, right? Now posteromedial papillary muscle is having blood supply from the posterior descending artery. This is very important. Why? Because it will get clear in a minute. So Post posteromedial papillary muscle is getting its blood supply from the first from the posterior descending artery, right? So now what is going to happen is that whenever a patient is going to have right-sided MI, right? And how do we know the patient is going to have right-sided MI? So if there is a problem in the 2, 3, and AVF, so if there is ST segment elevation in that, we know that right-sided coronary artery is affected. And when right-sided coronary artery is affected, it's going to affect the posterior descending artery in 70 to 80% of the cases. And as a result, on the third day, posteromedial papillary muscle will rupture. Now, when posteromedial papillary muscle gets ruptured, we are going to have mitral regurgitation, right? Because mitral valve is not longer competent. And when mitral valve is no longer competent, we are going to have mitral regurgitation. And what are the signs and symptoms of mitral regurgitation? So the signs and symptoms of mitral regurgitation are very common. So you are going to have symptoms of heart failure, right? So there would be pulmonary edema, there would be crackles in the lung, there would be dyspnea, right? There would be a shock-like condition in the body, and all of those things are going to be present in case of acute mitral regurgitation. So this thing is known as the acute mitral regurgitation. Now I want to ask you guys, where would you hear the murmur of acute mitral regurgitation? Anyone?
Apex.
Yes, so apex. And what would be the murmur be like?
Systolic.
Hollow systolic.
Holosystolic. And with the
Because
murmur radiate anywhere?
Left axilla.
Axilla.
yes to
Yes.
everywhere.
So it's gonna go into the axilla. So now they could give you a question. Now let me tell you how this question will come to you in the exam. So now they could give you a question that a person comes to you for myocardial infarction, and on the third day of this myocardial infarction, the patient is recovering very well. But all of a sudden, this patient is having dyspnea, and this patient is having late inspiratory crackles and bibasilar fine crackles as well in the lungs. Now, what do you do is that you auscultate the patient, and now you are hearing a new murmur, and that murmur is present at the apex, and that murmur is holosystolic. Now they could ask you what is the most likely diagnosis. So the most likely diagnosis here is the papillary muscle rupture that is leading to acute mitral regurgitation. Another thing that they could ask is what is the reason for this pathology? Or what is the pathophysiology? And the pathophysiology is that posteromedial papillary muscle is having a single blood supply. That is why this is happening, right? Or they could say, what do you think where the infarct would be present? So the infarct now would be present in the posterior descending artery, right?
Descendants.
Yes, and now they could even ask you which papillary muscle is involved in this thing. So the papillary muscle that would be involved is the posteromedial papillary muscle. Now sometimes interventricular septal. So now I told you that after 3 days macrophages are gonna come into the heart, and that macrophages are gonna repair the heart. But what happens is that sometimes if this is the left atrium, and if this is the right ventricle and this is the left ventricle, there is interventricular septum. So now what is going to happen is that macrophages are going to eat away this thing. So the macrophages would eat away this septum, and when this septum is going to get eaten away, there would be a interventricular septal defect, right? So there would be a ventricular septal defect. This is known as VST. Now again, they could give you a question that a person comes to you. Now again, this person is gonna have congestive heart failure symptoms, right? So again, in case of papillary muscle rupture and interventricular septal rupture, in both those conditions, there are gonna be symptoms of cardiogenic shock and pulmonary edema. So they would give you a person that on the fifth day is having dyspnea, is having pulmonary crackles, he is having bibasilar fine crackles, he is having hypertension, the patient is in tachycardia, the patient's leg are very yellowish, whitish, and the patient is having no pulses in the distal arteries, right? All of these are the signs of cardiogenic shock. And then they're going to tell you one important thing. When we auscultate the patient, now I want you guys to answer. What murmur would be here when we auscultate this patient? What murmur would be here?
Systolic.
Hollow
Where?
systolic.
Systolic murmur.
But the
Where?
site is internal
Left
body.
lower
Yes, so there would be a murmur, and the murmur would be holosystolic, and it is gonna be present at the
Left
left
sternum.
lower
left lower
sternal border, right? So this is how you are gonna differentiate between these two identical conditions. The only difference here is the what do you call the murmur, right? Now, at the same time, what could happen is that if this is the right atrium, right? If this is the right atrium, and if this is the left ventricle and this is the right ventricle, sometimes what could happen is that instead of this interventricular wall getting ruptured, this thing can get ruptured. So this is the free wall of the right left ventricle. Now what is the structure in which the heart is enclosed?
Pericardium.
Pericardium, right? Right. So there is the here will be the pericardium. So all of the blood is gonna go out, and all of the blood is gonna get stuffed in here. And now, whenever the blood goes in the pericardial cavity, we call that thing as the cardiac tamponade. Right. So there would be cardiac tamponade. Now, what are the signs and symptoms of cardiac tamponade? That is very easy. There is a triad of triad, right? And that triad is known as the Beck's triad, right?
Beck's triad.
So now this patient is going to have Beck's triad. And now, what is Beck's triad? So in case of Beck's triad, first of all, you're going to have hypertension, right? So there would be hypertension that would be present in case of Beck's triad. And then what are the other three things? What are the other two things that were going to be present there?
Muffled heart sounds and low
Yes.
blood pressure.
Yes, so there would be distended JVP, and then there would be muffled heart sound. And the third thing is that there is gonna be hypertension as
Low
well.
blood pressure.
Yes. So if they give you a question and they say that a person presents to you with dyspnea, cardiogenic shock at the fourth day or fifth day, and there is elevated JVP, there is muffled heart sounds, there are hypertension, and the ECG shows electrical alternance, right? Or the ECG shows low QRS complex waves, and there is electrical alternance, right? So this thing is gonna be known as. So now we would call this thing as, you can say, Beck's triad, or this patient is going to have ventricular free wall rupture, right? Now, only two things are left behind: ventricular pseudoaneurysm and ventricular aneurysm, right? So, what is ventricular pseudoaneurysm, right? So, what will happen? So, if this was the heart, let me show you a picture. There is a very good picture here. So, if this was the ventricular wall, So what will aneurysm means a dilation, right? So ventricular pseudoaneurysm means that this wall is ruptured now and a small amount of cavity of blood is formed outside this wall. This is known as the ventricular pseudoaneurysm. Normally it is asymptomatic and it won't cause a lot of problems, right? This won't cause a lot of problems. If it gets ruptured, there is gonna be free cardiac tamponade. The important thing here is the ventricular aneurysm. And the ventricular aneurysms occurs after 2 weeks, right? And the most important thing here is that how would you diagnose the ventricular aneurysm? Now the question would say that if the patient is having ventricular aneurysm, that patient would have persistently elevated ST waves. In case of ventricular aneurysm, the patient is going to have persistent ST elevation. Like, so for example, if a patient is having MI after 10 days or after 2 or 3 days, the STL segment elevations are going to go back to normal. But if a patient comes to you after 2 months and the patient is still having symptoms of heart failure after MI, and they say this patient's ST segment is still elevated, then it means the patient is having ventricular aneurysm, right? Now, this was very easy. Now, one thing is left behind, which is the Dressler syndrome, right? So, what is Dressler syndrome? So Dressler syndrome means that the patient is having, so when the heart was damaged, a lot of antigens was released in the blood. Now, against these antigens, the body is gonna mount a response. So there would be an autoimmune response, and that autoimmune response is gonna damage the pericardium. And again, there would be a pericarditis. Right. So if there is pericarditis after several weeks, then that pericarditis is known as the Dressler syndrome or the post-cardiac injury syndrome. In this condition, we will give the patient NSAIDs and colchicine. Right. So in this condition, we are going to give the patient NSAIDs plus colchicine, and that would improve the patient. No need to give aspirin in this condition. Right. So that was it. So Dr. Nafira, are you still having any? No, in
No.
case of Dr. Sana, in case of post-infarction fibrinous pericarditis, we give the patient aspirin. We cannot give patients NSAIDs, right? Right?
Yes.
Okay. Okay, Dr. Mospin, pseudoaneurysm pathology. Okay. So pseudoaneurysm is very easy, right? So what happens in pseudoaneurysm is that if this was the, so if this is the heart, if this is the left ventricle, what will happen is that there would be a very small leak here, not a very big leak, a very small leak, and this small leak will contain a cavity like this, right? So blood will go out here, so blood is gonna go out here, and what is gonna happen is that so blood will go out here, and pericardium is gonna wrap this thing like this, and we are gonna get a pseudoaneurysm, right?
And pseudoaneurysm
So
will
the
not be
that
associated
that is
with
the pathological, right?
pseudoaneurysm will not be associated with ST elevation. Yes, only true aneurysm.
Yes, they won't.
Ventricular.
Yes. Now,
Thank you.
welcome.
Because of,
Okay, so
excuse me,
one more
Dr.
thing
Moss,
regarding,
because of myocardial infarction, the
yes,
true ventricular aneurysm develops or pseudo ventricular aneurysm develops?
I didn't guess. Can you repeat your
Uh,
question?
After MI, because we are discussing
Hmm.
the MI complications. So
Yes.
is it the pseudo or is it the true ventricular
So
aneurysm?
pseudoaneurysm can develop as well, and true aneurysms can develop as well. It depends upon the timing. So you have to look at the question. If the aneurysm that is developing is within 2 weeks, then the aneurysm would be a pseudoaneurysm. But if the signs and symptoms start coming after 2 weeks, then it is gonna be a true ventricular aneurysm. Both of these conditions can occur, but it depends upon the time, right? So if it develops later if it develops in some months, then it's the true aneurysm. But if it's developed within 2 weeks, then it's a ventricular pseudoaneurysm. Now, one more important thing, in case of ventricular aneurysm, the problem that is happening is there is going to be dilation of the heart. There is going to be a lot of blood that is going to be stuck in the heart here, right? That is the thing that is going to happen in the ventricular aneurysm. And I told you guys already that whenever there is a lot of blood in the heart or a lot of stasis anywhere, a lot of thrombus are going to form there, a lot of clots are being formed there, right? So they could give you a question that a patient comes to and that patient had a ventricular aneurysm, and now that patient is having a stroke. So why this patient is having stroke? Because due to ventricular aneurysm, a lot of clots are now being formed in the heart, and that clots are going all over the body, right? So they can cause a lot of problems. Now, let's move. Okay, Dr. Fatima, did you had a question?
Yeah, so you mentioned that there won't be any ECG differences in pseudo aneurysm. So what are the other symptoms that we could point it towards pseudo aneurysm, or have a diagnosis for pseudo
Okay.
aneurysm?
Okay, so in case of ventricular pseudoaneurysm, there would be emboli. So first thing, there would be emboli, right? So there would be emboli. Now, the second thing is that there would be chest pain, and there would be signs of heart failure as well, but there would be no murmur, right? So if I summarize here it on the first check, I want to tell you the main things regarding different things, right? So if any complication is occurring within the first 3 days, right, and there are ST segment elevations in diffuse leads, then it would be post-infarction fibrinous pericarditis. If a patient is having holosystolic murmur at the axilla, right, within 2 to 7 days, after 3 days, then it's gonna be papillary muscle rupture. If a patient is having symptoms of heart failure and there is a holosystolic murmur at the left lower sternal border, then it's interventricular septal rupture, right? Now, within 2 weeks, if a patient is having symptoms of heart failure, right, and there is embolism as well, then it's gonna be ventricular pseudoaneurysm, but there won't be any murmur here. Then, if a patient is having Beck's triad within the first 2 weeks, then it's ventricular free wall rupture, right? Now, if a patient is having if a patient is having ST segment elevations, even after some weeks of MI, and there is heart failure as well, then that is going to be true ventricular aneurysm. Now, if a patient is having chest pain that gets relieved when the patient is leaning forward and gets worsened when the patient lies back, and there is pericardial friction rub as well, and there is diffuse ST segment elevations as well, then it's going to be post cardiac injury syndrome, right? So so I want you guys to have these things on the fingertips like this as well, right? So try to make these things as clear as possible. Yes, so for the restless or for the post cardiac injury syndrome, we are going to give the patient NSAIDs and colchicine, right? For post MI fibrinoid pericarditis, we give the patient aspirin, right? That is exactly right. Now, what is the treatment of acute coronary syndrome, right? So the key treatment of acute coronary syndrome is very simple, right? So there is a mnemonic, and that mnemonic is known as the Monabash, right? So remember the Monabash mnemonic. So whenever a patient is having MI, you are going to give the patient Monabash. Monabash, right? So in Monabash, M stands for morphine. So first of all, you are gonna give the patient morphine. Then you are gonna give the patient oxygen. N stands for nitrate. A stands for aspirin. B stands for beta blockers. A stands for ACE inhibitors. S stands for spironolactone, and H stands for heparin. Right. So if you look here now, this mnemonic is gonna make things a lot more easier. Right. So if you look here, you can see in unstable angina. First of all, you give the patient heparin, and then you give the patient aspirin. Then you give the patient clopidogrel. So when do you give the patient clopidogrel? If the patient is going to have a, so now whenever a patient comes to you with STEMI, you have to give the patient percutaneous coronary intervention within the first 90 minutes. If you cannot give the patient percutaneous coronary intervention within 90 minutes, then you are going to give the patient fibrinolysis with the help of streptokinase, right? And if you give the patient percutaneous coronary intervention, then you follow the patient with aspirin plus clopidogrel for 12 months. Then you give the patient aspirin plus clopidogrel for 12 months.
So if we aren't able to give percutaneous coronary intervention within 90 minutes, you said we need to do fibrinolysis via streptokinase, right?
Yes, yes, exactly. So we give the patient
But is it
fibrinolysis.
because of any?
And after that, what we need to do about aspirin, what you said, after how many minutes we need to do it?
After 90 minutes, no. So if we wait, so we have to give the percutaneous coronary intervention within 90 minutes, right? But if it's not available within 90 minutes, then you give the patient fibrinolysis. But they can ask you another question: is fibrinolysis better or is percutaneous coronary intervention better? So the percutaneous coronary intervention is 1,000 times better than fibrinolysis, right? Okay.
Could there be any
Secondly,
contraindications?
in case of what?
Okay. No. Would there be any reasons like contraindications for not being able to do the procedure? Like, why wouldn't the procedure be given?
The percutaneous coronary intervention?
Because
Yes.
every hospital does not have lab. Every
Exactly.
hospital does not have the facility.
Yeah, because in rural areas it is not available.
Like
We can give the first line in rural areas.
so I was a so back some years back I was a third year student, right? And I just started my USMLEs, right? So I was starting my USMLEs and I had done the first aid. And so my father's brother had a heart attack, right? So my father brother had an MI, myocardial infarction, right? And we went to the cardiology hospital in our city. So we went there and we asked them that you should do a coronary intervention because that is what I had stated, right? But since it was 8 in the evening, so they said that no attending is available here for the coronary intervention, right? And they just did fibrinolysis. So that is why we have guidelines for that, because a lot of hospitals, a lot of places don't do percutaneous coronary interventions at a lot of time because there is a lot of resource limitations, right? So due to the
I
resource
understand,
limitation.
doctor. I understand about the resource limitation. My question was, is there any other medical condition or reasons where this procedure is like not allowed, apart from resource limitation?
Okay, so for percutaneous coronary intervention, no. For percutaneous coronary intervention, there is no kind of contraindication that would say that would not allow you to do. But yes, for fibrinolysis, there are a lot of contraindications, right? There are a lots of contraindications regarding the fibrinolysis, and you have to remember those as well, right? So when we do the stroke, I could tell you. So when we will do the stroke, I could tell you the fibrinolysis contraindications. Or let me just tell you the main ones here, right? So if a patient had so if a patient has any history of intracranial hemorrhage, right? If the patient has any kind of intracranial tumor, if the patient had an ischemic stroke 3 months ago, if the patient has suspected aortic dissection, if the patient had a recent surgery or a recent head trauma, right? Or if the patient is on any has any kind of bleeding disorder, then all of these are the
Like peptic ulcer.
contraindications for
Um,
Dr.
yes.
Mahas, I have a question. With regards to aspirin and clopi, dual antiplatelet therapy, do we only give it once we do the PCI because of the stent in place? What happens if patient underwent fibrinolytic therapy?
Okay. Uh, so if we know that we are going to start the percutaneous coronary intervention, we load up the patient on clopidogrel, right? If we know that we are starting on the patient, so we don't load up on it, right? But if we are going to give fibrinolysis to the patient, then we do not give the clopidogrel. Like even in the case of fibrinolysis, we withhold the aspirin as well, right? So we withhold the aspirin as
And
well.
thank you. And the reason we give clopi is for the stent, and we continue dual antiplatelet therapy for 12 minutes.
Okay, so now again there are two things regarding it, and yes, they like it. So there are two things. One is the DES, another is the bare metal stent, right? So we can do two kind of stenting in case of a percutaneous coronary intervention. One would be known as the drug-eluting stent, and the other is the bare metal stent, right? If we give the patient a bare metal stent, right? So when do we give the patient their? So this is an important thing, right? And they could ask you this in the UWorlds and the NBMs. So if we have a thing that we think that the patient is would be non-compliant with the medication, especially with the clopidogrel, then we give the patient a thing which is known as the bare metal stent, right? This does not have good outcomes, right? So the outcomes are worse, and there would be again atherosclerosis in the place of bare metal stent. Whereas we have another stent which is known as the drug-eluting stent. And the drug-eluting stent is much better than the bare metal stent. But for the case of drug-eluting stent, you have to give the clopidogrel for 12 months. Whereas in the case of bare metal stent, you just give it for 1 month, right? So that are the guidelines. And they are going to ask you this, right? So they are going to definitely ask you this, that why do we give the patients bare metal stent? So if do you think, if you think that the patient is having these problems, then you give the patients bare metal stent. Then you think that the patient is not going to take the medications for 12 months, right? Okay. Let me see the question. Yes, so there is a
Is
golden period.
Mona Bash.
Okay. Okay.
Could you
So Monabash stands for Okay, so now first of all we are gonna do Monabash. So Monabash, in Monabash, M stands for morphine, right? O stands for oxygen, N stands for nitroglycerin, A stands for aspirin, B stands for beta blockers, right? A again stands for ACE inhibitors, S stands for statins, H stands for heparin. Now the important thing here is that the let me mark this for you guys, right? So the things I'm marking with pink, right? These are the things that improve the mortality outcomes in heart attack: beta blockers, ACE inhibitors, and statins, right? Along with another drug which is known as the spironolactone, right? So these are the four drugs that improve mortality in case of myocardial infarction, and keep these drugs in your mind, right? So if whenever a patient comes to you and this that patient is having these, and they ask you what drugs are going to improve the mortality, and this is a very common question in new worlds and step one, and this is very, very high here, right? So what drugs improve the mortality? So only beta blockers,
That
ACE inhibitors, statins, and spironolactone are the drugs that are gonna improve the mortality, right? Diuretics and digoxin improve the hospitalization. They reduce the hospitalization, but they do not improve the mortality of the patient, right? They have no mortality benefits. Again, loop diuretics, nitroglycerins, digoxin, all of these things do not improve the mortality, right? Now there are two other diabetic drugs. So if the patient is having diabetes, there are two other drugs that are going to improve the mortality. And NBMEs and UWorld are going to ask you those two drugs as well. What are those two drugs? So the first drug is Ozempic. So that is a GLP-1 analog. So if a patient is having diabetes and myocardial infarction or any other vascular problem, then you give the patient GLP-1 analogs. And if the patient is having heart attack and the patient has diabetes, you give the patient SGLT2 inhibitors as well. Both of these things are very important, right? Okay. Now we are gonna move on to
Sorry,
repeat. Okay.
Dr. Moss, the last two bits that you mentioned, GLP-1 analogs and SGLT2 inhibitors, what do they do? We give them in diabetics with them, but do they have any mortality benefits?
Yes, they have a lot of mortality benefits. So the latest researches show that they improve the mortality outcomes by 25%, right? So if there is any diabetic in even in your family and that patient, because a lot of diabetics have strokes and they have mm, myocardial infarctions as well, or they have angina as well. So if there is any vascular event that is occurring in a diabetic patient, and even if this patient is in your family, please do try to incorporate GLP-1 analogs and SGLT2 inhibitors into their diabetic regimen, right? They are going to improve the mortality outcomes. And UWorld and NBMEs are going to bombard you with these questions, right? They want you to know that GLP-1 analogs and SGLT2 inhibitors are improving mortality outcomes in the patient of diabetes, right? So always, always, always consider these drugs, right? So these drugs are very good for diabetics. Now, let's move on to cardiomyopathies. Right? So what are cardiomyopathies? Cardiomyopathy basically means that your heart is having any kind of problem, right? So basically, your heart is having a problem, and there's a pathology in your heart, right? So these are genetic pathologies normally. Now, what is dilated cardiomyopathy? So dilated cardiomyopathy means that you are having a problem with the systolic function of your heart. Remember, on the physiology thing, we talked about two things. The number one was the systolic function of the heart, and the second one was the diastolic function of the heart. So during the systolic function, so if the systolic function of the heart is affected, then the patient may have dilated cardiomyopathy, and dilated cardiomyopathy is due to problem in the systolic function of the heart. Now, normally I told you that in case of myocardial infarction, either the left side of the heart is affected or the right side of the heart is affected. But if we have a problem that is affecting the both sides of the heart, then that would be a dilated cardiomyopathy. So in case of dilated cardiomyopathy, there is biventricular heart failure. This is very important. In case of dilated cardiomyopathy, we are having biventricular heart failure. Both of the ventricles are going to fail, the right and the left ventricle as well. Whereas in case of myocardial infarction, usually one ventricle is affected. Normally the left or the right ventricle is affected. And how are you going to know which ventricle is affected? You're going to see the ECG, right?
Doctor,
So if
can you
there is
please repeat
a
one more
problem in the
time?
V1, V2, V3, V2. Yes, okay.
Can you
So
please?
I was telling you that, yep. Okay, I'll repeat it. So I was telling that there could be a lot of so now I was telling you that heart can fail due to a lot of reasons, right? One reason is that there was atherosclerosis in the coronary vessels, and that led to the ischemia of the heart. But normally, atherosclerosis affected only one kind of a vessel. Maybe it affected the left coronary vessels, and there were ST elevations in one V1, V2, V3, V4, and you know that the anterior side of the left heart was affected. Now, maybe there was elevation in one AVL and those sites and V5 and V6, then you know that the lateral side of the left heart was affected. And if there was elevation in 2 3 AVF, then you know that the right side of the heart was affected. But in the case of dilated cardiomyopathy, this is a disease which affects both sides of the heart. It is going to cause both sides of the heart to go away, to die, right? And then the patient is going to have systolic dysfunction on both sides of the heart. Right. This is the most common cardiomyopathy. Now, there are a lot of reasons for this condition, and all of these conditions are very, very important. So, the first one is alcohol. Right. So, if a patient is drinking a lot of alcohol, the patient is going to have alcoholic cardiomyopathy. Right. And in that conditions, there would be symptoms of heart failure. And I think that by now you know all the symptoms of heart failure, right? Yep. Okay.
Yes.
So now there would be heart failure. And whenever there is heart failure, during the physiology, we studied that heart failure causes an S3 heart sound, right? So whenever you hear an S3 heart sound, that thing is very specific for heart failure. That thing is very, very, very specific for heart failure. So if you see an S3 heart sound, always think that this patient is having a systolic heart failure. And now there could be different reasons for dilated cardiomyopathy. The treatment for dilated cardiomyopathy is exactly the same as for the myocardial infarction. You give the patient ACE inhibitors, you give the patient ARBs, you give the patient beta blockers, you give the patient spiral electron, all of those things, right? And there is systolic dysfunction. Now, the one cause could be alcoholic cardiomyopathy. Now, the second cause could be cocaine, but that is not important. The third one is very important, which is doxorubicin. What is doxorubicin? So basically, doxorubicin is an anti-cancer drug. So whenever a patient is having cancer, we may give the patient doxorubicin, right? So we give the patient doxorubicin whenever the patient is having cancer, right? Now they could give you a patient that a person comes to you, and that patient was having cancer, right? And you give the patient some drugs. And now this patient is having symptoms of heart failure, and you see that this patient is having S3 heart sound as well, right? So this patient is having symptoms of heart failure, and this patient is going to have S3 heart sound as well, right? Now, the next thing is that they're going to ask, what is the cause of this condition? So the cause of this condition is going to be doxorubicin. The second thing is that they're going to ask you the pathophysiology of this condition. So remember, in case of dilated cardiomyopathy, the thing that occurs is if this is the heart, what will occur in dilated cardiomyopathy is that this thing is going to get bigger. A lot of more fibers are going to be added in this way. And this is known as the series addition, right? So a lot of heart muscles are going to be added in series, and that is known as the eccentric hypertrophy. Remember, the eccentric hypertrophy, it is very important, right? So whenever a patient is having dilated cardiomyopathy, the patient is going to have eccentric hypertrophy. Now there are some other causes. Now the patient could have myocarditis as well. What is myocarditis? Myocarditis means that the patient is having an inflammation of the patient's heart, right? And the patient is having a viral infection of the myocardium. Now, how does myocarditis presents? Myocarditis normally presents with, first of all, the patient is going to have symptoms of viral infection. So there would be symptoms of upper respiratory tract symptoms. The patient is going to have sneezing, the patient is going to have runny nose, the patient is going to have watery eyes, the patient is going to have symptoms of all of those things, right? This is the thing that is going to happen in myocarditis, right? And after that, the patient will complain of dyspnea, the patient will complain of orthopnea, there will be pulmonary edema, and the patient will develop symptoms of heart failure. Now, what are the organisms that cause myocarditis? The most common one is Coxsackie virus. And then there is Chagas disease as well, right? So Trypanosoma cruzi causes Chagas disease, and then the patient could have uh, myocarditis and dilated cardiomyopathy as well, right? Now, you could skip hemochromatosis, sarcoidosis, thyrotoxicosis, but one thing is very important, and that is peripartum cardiomyopathy. What is peripartum cardiomyopathy? some females, when they get pregnant, they are gonna have, so when some females get pregnant, they are gonna have heart failure, right? If heart occurs during the pregnancy or 2 months following, 4 months following by the pregnancy, then the patient is gonna have a condition which is called the peripartum cardiomyopathy. And normally this condition resolves on its own. You just give the supportive treatment and the patient gets better. Now, there is another thing which is known as a Takotsubo cardiomyopathy. Whenever a patient all of a sudden gets a sympathetic stimulation, like if the patient gets a lot of stress, or if a patient fails the exam, or the patient hears that my father has died, or a patient says that my brother has died, or my husband has died, or my wife has died, there could be a lot of sympathetic stimulation in the body. And as a result of sympathetic stimulation, the apex of the ventricle starts ballooning and the patient has dilated cardiomyopathy. And this condition is known as the stress cardiomyopathy or the dilated cardiomyopathy. Uh, what is the prognosis of this condition? The prognosis is very simple. The patient improves in almost all of these conditions, and the patient is gonna get better in almost all of the conditions, right? Now we are coming on to the second thing, which is very, very much tested in you world and NBMs, and this is very high here, and that is the hypertrophic cardiomyopathy, right? So the second condition is the hypertrophic cardiomyopathy. And what is hypertrophic cardiomyopathy? In case of hypertrophic cardiomyopathy, there are mutations. There is This is an autosomal dominant disease, so it runs in family. There would be some kind of family history as well, and there would be mutations in the beta myosin heavy gene or the myosin binding protein C. Now, how would the patient present? So the patient would be a very young patient between 20 to 40 years age, and the patient would say that whenever I exercise, I get syncope, I get fainted, or I have dyspnea whenever I exercise. And the patient would say that I have a family history of my father or my uncle or someone dying with due to heart problems in their early 20s or 30s. Right? Now, what is the problem in hypertrophic cardiomyopathy? So in hypertrophic cardiomyopathy, the heart deletion of there is concentric hypertrophy, and there are additions of fibers or sarcomeres in the parallel. Right? Now, when the heart's lumen gets so small, a very little amount of blood can come into the heart. And when little amount of blood can come into the heart, the preload of the heart is going to decrease a lot. And when the preload of the heart decreases a lot, less amount of blood can be pumped out of the heart and the contraction of the heart is impaired. Right? Now, since in this condition, it is very simple. There is ventricular hypertrophy here. You are going to hear a S4 heart sound. The heart is going to get very stiff. And I told you when the heart gets very stiff, you are gonna hear an S4 heart sound, right? Now, what is the treatment of this condition? The treatment is very simple. I told you that most of the heart gets filled in diastole, and if we slow the heart rate, more heart is gonna be filled. So what do? We slow the heart rate. And how can we slow the heart rate? We can use beta blockers or calcium channel blockers, right? And we ask the patient not to do any kind of athletic activities. And if the patient is very high risk, if the patient added syncope first, we insert an intracardiac device. Now, one more thing that is important here is the fact that these patients, you do not give any drug that reduce the preload. So, for example, nitroglycerin reduces the preload of the heart, right? Can anyone tell me how does nitroglycerin reduces the preload of the heart, please?
Yes, because it leads to the venodilation, which further decreases the flow.
Venodilated.
Improve the venous tone.
Because it's
Okay, so it
dilatation.
decreases. Okay, so what does it do is that it decreases the venous tone. When the venous tone is decreased, an increased amount of blood, a decreased amount of blood is going to come to the heart, and preload is going to be reduced. And now this poor man heart is already being filled so low. So whenever you give the patient these things, the patient is going to get so much worse. Similarly, diuretics also reduce the blood from the body, and as a result, the preload is going to be reduced. Right? What is restrictive cardiomyopathy? Restrictive cardiomyopathy is very simple. It In restrictive cardiomyopathy, you can just look up the causes. It's not very high yet. I'm not going to go into the detail of this because I don't think it's tested a lot. Right? But you can just think that in restrictive cardiomyopathy, the heart cannot stretch. Right? So when the heart cannot stretch, you are going to get restrictive cardiomyopathy, and again there would be problem in filling. Right? But it is very different from hypertrophic cardiomyopathy. So two important things. If there is a systolic dysfunction of the heart and you hear an S3 heart sound, then it's most likely dilated cardiomyopathy, right? And what's the pathophysiology of dilated cardiomyopathy? In dilated cardiomyopathy, new fibers are being added in series and there is eccentric hypertrophy. Whereas in case of hypertrophic cardiomyopathy, new fibers are being added in the parallel and there is concentric hypertrophy in case of hypertrophic cardiomyopathy. Right? Now, if anyone has, does anyone has any question? If not, we are gonna move forward.
Please, could you please explain the difference between eccentric and concentric? I don't.
Okay, sure. Imagine this is a circle, right? Right. So this is a circle, and we have these small tiles, and we wanna make this circle. We wanna adjust these tiles into the circle. How can we do this thing? We can add the tiles in two ways. Maybe we could add the tiles like this. So when we add the tiles like this circle is gonna get thicker, right? This is known as the concentric hypertrophy because concentric means around a circle. So it means center, right? So it means near a center. So you are adding things near a center. So this is the concentric hypertrophy, right? Whereas in the case of eccentric hypertrophy, what is going to happen is that we are going to cut the circle and we are going to add things. So what will eventually happen is that we are going to make this circle this much big. So for example, if there were 4 things here, we are going to add 4 more or 8 more. And this is going to become something like this. So it means eccentric. So E means away. So it is a Latin word and E means away, right? And center means center, right? So eccentric means away from the circle, right? So in case of eccentric hypertrophy, if this is the circle, we are going to move away from the circle. We are going to make the circle bigger. We are moving away from the center point, right? So we're going to make it bigger by moving away from the circle. Whereas in concenter means we are moving towards the center. So if this is the center, we are moving towards the center. So we are moving towards the center. So concenter means toward the center, and we are making our heart small and small, and we are going to make the lumen small. So this is what is going to happen in the concentric hypertrophy, whereas in eccentric hypertrophy, the circle is going to get bigger. Now, if we look at this picture here, you can see it clearly. See the left ventricle, it has become so big because all of the fibers are being added in the eccentric way. Whereas here, the heart has become so small, right? Because see, normally the heart was the normal heart was like this. Now, what did the body do? The body added more fibers like this, right? Then it added another layer, then it added another layer, and only this volume remained. And so the lumen is so small that nothing can be filled in this heart. Now we are going to move to the heart failure, right? So what is heart failure? This is the thing that we have been studying from the first day, right? So it means that the cardiac pump cannot function properly. There is congestion and there is low perfusion. What are the symptoms? You already know the symptoms. There would be dyspnea, there would be orthopnea, there would be fatigue, and there would be S3 heart sound, right? There would be jugular venous distension in right-sided heart failure. There would be pulmonary edema in the left-sided heart failure. This is the systolic function, right? Now, if we move to the systolic heart failure, the thing that you can see is that ejection fraction is reduced and diastolic volume is increased, which means preload is increased. Why? Because the heart cannot pump out all of the blood. So more amount of blood is going to remain in the heart and that is going to increase the preload. Now, preload is increasing, the heart cannot function properly, so the contractility is going to decrease. It's most likely due to ischemia, myocardial infarction, or some dilated cardiomyopathy as well. Now, diastolic dysfunction. What happens in diastolic dysfunction? In diastolic dysfunction, the heart cannot get enough blood, right? So the heart cannot get enough blood. So when the heart cannot relax completely, it cannot get enough blood. So what will happen is that a lot of blood won't go into the body and that would cause diastolic heart failure. Now there are two kinds of heart failure. There would be left heart failure, there would be right heart failure, right? Now both of these are different, right? So if I say that a patient is having biventricular heart failure, what would come into your mind?
Diastolic heart failure.
Dilated cardiomyopathy.
Dilated
Yes,
cardiomyopathy.
so dilated cardiomyopathy, that would come into your heart, right? Now, if the patient is having only right-sided and left-sided heart failure, then that would be due to what you could say ischemia, right? Now, again, there are some mortality improvements drugs. And what are those? ACE inhibitors, ARBs, angiotensin neprilyzing inhibitors, beta blockers, aldosterone receptor antagonists, right? Loops and thiazides are only used for symptomatic relief, right? Now, SGLT2 inhibitors and Ozempic improve the outcomes in some patients. Now, what are the symptoms of left-sided heart failure? These are very simple. In case of left-sided heart failure, you are going to get short of breath when you lie down. Why? Because as soon as you lie down, venous return from the body increases, and that is going to go to the heart. Now, increased amount of blood is coming to the heart, and heart cannot pump out all of the blood, so you're going to get orthopnea. And when you sleep, venous return from the body again increases, and that is going to cause you to wake up from the sleep. And again, pulmonary edema occurs due to a lot of blood going back from the left atrium to the left heart. These are all the signs and symptoms of left-sided heart failure. So whenever a patient with heart failure or dyspnea comes to you, always look that whether this is a right-sided heart failure or the left-sided heart failure. And there are three symptoms of left-sided heart failure, and there are three symptoms of right-sided heart failure. Now, what are the symptoms of right-sided heart failure? So in case of right-sided heart failure, they would be first of all hepatomegaly. Why? Because right atrium is connected to the inferior vena cava, right? And inferior vena cava goes directly into the liver. So whenever there is inferior vena cava problem or there's problem with the right atrium, all of the blood is going to go back into the liver, and there would be increased pressure in the liver, and that is going to cause cardiac cirrhosis. So that is a cirrhosis that is caused by due to the heart, and that is known as a cardiac cirrhosis. And there would be network liver as well, and then there would be JVD distension and peripheral edema as well. Right now, let's first do cardiac tamponade. So what is cardiac tamponade? I have already told you that in cardiac tamponade, the heart is being compressed by blood, right? So heart is being compressed by blood. When the heart is being compressed by blood, the heart cannot pump out all of the blood, and the cardiac output decreases, right? Now, what are the findings? The findings are very easy. There would be back triads, right? There would be pulsus paradoxus, right? So what is pulsus paradoxus? We would go into the detail in the next lecture because that is a detailed topic. The echocardiogram would show pleural effusion as well because the blood is going to get collected in the pericardial space. So there would be pericardial effusion, right? What's the treatment? The treatment is very simple. We do the pericardiocentesis or surgical drainage in these patients, right? Now, let me see. Okay. Now let's do acute pericarditis. So we have done acute pericarditis. So it was very simple. There was inflammation of the pericardium, and there was sharp pain that was aggravated by inspiration and relieved by sitting up and leaning forward. And when you lie down, the pain became worse, right? There was friction rubbish with ECG showed diffuse ST segment elevations, right? So normally it happens due to viral infections, some kind of malignancy as well. So breast cancer is the one that leads to acute pericarditis. Cardiac surgery again does acute pericarditis. Why? Because a lot of antigens are released, and that leads to Dressler syndrome, right? Now again, MI causes this as well, and some autoimmune diseases as well. The important thing here is the renal failure. So whenever a patient is having renal failure, there would be uremia, and uremia leads to pericarditis. And the treatment for uremia-induced pericarditis is very simple. You start the patient on dialysis. So as soon as you start the patient on dialysis, the patient gets better. So now we are done with the syphilitic heart disease as well. Now we have discussed rheumatic fever a lot of times. So what was rheumatic fever? So rheumatic fever was an infection, was a consequence of the infection of with group B streptococcus. So whenever there was group B streptococcus infection, the patient would make antibodies against the heart and the joints, and the patient would have rheumatic fever. It usually happens in the developing countries, right? And first of all, there would be regurgitated murmurs, and later there would be stenosis murmurs, right? So this is the thing. So guys, there are very small things in the first aid, but some small things are very important, right? So like early valvular regurgitation and late valvular stenosis, right? So normally rheumatic fever affects the mitral valve. And I think someone asked me this question back that what valve would be affected by the rheumatic fever. So the first valve that you're going to think of is the mitral, and then aortic, and then tricuspid, right? And there would be Ashkoff body and its cow cells as well, right? So you have to remember the description. And how do you know that the patient is having rheumatic fever? So in order to know that if the patient is having rheumatic fever, you're gonna check the patient's anti-streptolizin over titers, and at the same time you check anti-DNSB titers as well. This is an immune mediated. Why? Because there would be an M protein there would be M protein that would self react with heart antigens as well, and it would damage the heart. If you give the patient penicillin during the treatment of streptococcus infection, the patient won't have rheumatic fever, right? So rheumatic streptococcus infection can cause two things. One is that it could cause rheumatic fever. The second thing is that it could lead to post-streptococcal glomerulonephritis. If you give the patient penicillin, the risk of post-streptococcal glomerulonephritis reduces. No, does not reduce. So the risk of post-streptococcal glomerulonephritis does not reduce, whereas the risk of uh, rheumatic fever reduces. Right. So now, what are the signs and symptoms? The signs and symptoms are very simple. The patient is going to have joint pain. The patient is going to have carditis of the hearts. The patient is going to have subcutaneous nodules. The patient is going to have erythema marginatum, and the patient is going to have syndrome chorea. Right. So, guys, let's keep our topics, our discussion till here today. Right. So now, uh, we are just left with arrhythmias and some topics, and most likely we are going to complete. No.
Also, Dr.
So
Moaz,
the athletes are, yes. In
can you clarify what is systolic and diastolic dysfunction?
Okay. So, so what is systole? So systole basically means that the contraction of heart, right? So the heart has two phases. The one phase is the systolic phase during which the heart contracts. And what does the heart contracts? The heart contracts, it pumps the blood out of the heart. Now, in order to pump the blood out of the heart, we need to have some blood in the heart as well, right? So the blood in the heart gets collected to the diastole, right? So there are two phases. One phase is the diastolic phase, and the other phase is the systolic phase, right? So if a disease or a problem causes the heart not to pump properly or not to contract properly, then the patient is going to have the systolic dysfunction of the heart. And if the disease causes the heart not to relax properly, so the heart is not relaxing properly, and there is diastolic dysfunction of the heart. And that thing would be known as the diastolic dysfunction, in which the heart won't fill properly, right? That is the diastolic dysfunction in the heart. And the end symptoms are going to be very much same. Why? Because you're not giving enough blood to the body. The body is not getting enough blood. In one case, you do not have enough blood to give to the body. That is the diastolic heart failure. Whereas in systolic heart failure, you have a lot of blood, but the heart is not capable of giving that blood anymore to the body, right? So just imagine a car, right? So a car has an engine and a car has a reservoir or a tank. In order to run a car, you need fuel in the car, right? So if you inject a lot of fuel in the car, but the car's engine is not functioning properly, you cannot drive that car. That car is going to just sit there. And if you keep pumping more and more fuel into the car, what will eventually happen is that the fuel is going to spill back. The fuel is going to go into your house if the car is standing in your house. Then you're going to have the problems, right? So what's the exact location of VSD and HOCM, right? So both the VSD and HOCM occur at the same place. They are going to occur at the left lower sternal border of the heart. But in the case of HOCM, the murmur is going to be crescendo, decrescendo, systolic murmur. So there are two crescendo, decrescendo systolic murmurs. One is the murmur of HOCM, the other is the murmur of aortic stenosis. But the murmur of aortic stenosis is heard at the right upper sternal border, whereas the murmur of VSD is heard at the left lower sternal, and the murmur of HOCM is left at the left lower sternal border.
Dr. Moaz,
Yes, Dr. Muskan.
I'm sorry, I got disconnected while you were talking about the contraindications of fibrinolysis. Can you please repeat them one time more?
Yes. Why not? Right. So what, first of all, we want to look at the indications, right? So the indications are very simple. So one is STEMI. So whenever a patient is having STEMI, we can give the patient fibrinolysis. But when do we do the fibrinolysis? We want to give the fibrinolysis when you can't give the percutaneous coronary intervention. You should give the percutaneous coronary intervention within 90 minutes, and at max it should not exceed 120 minutes, right? But if you cannot give the patient percutaneous coronary intervention, right, then you can give the patient fibrinolysis. What are the contraindications? The contraindications are very simple. If there is any active bleeding, if the patient has any bleeding disorder, if the patient has any history of intracranial bleeding, if the patient has any history of hemorrhage, if the patient has any history of tumor in the brain, or if the patient has any tumor in the brain, if the patient had any stroke within the past 3 months, if you think the patient is having any cancer of the patient, if you think the patient is having any aortic dissection, right? So all of these are the contraindications for fibrinolysis, right?
Dr. Moaz, I'm
And
sorry to ask you again one question about the systolic and diastolic heart failure. Would you be kind enough to repeat it, please?
So the systolic versus diastolic, right?
Yes.
Okay, guys. So systolic heart failures mean that your heart is not pumping properly, right? There's a problem with the pumping of your heart, right? So your heart cannot pump out all of the blood. Your heart is very weak. Your heart cannot contract effectively, and it reduces the amount of blood that is pumped out of the heart. For example, 100 ml of blood is coming into your heart. Normally, if 100 ml of blood comes into your heart pumps out 70 ml of blood. But what if I say that due to ischemia or due to any other problem, due to alcohol or peripartum cardiomyopathy or doxorubicin, your heart has become very weak. Now it cannot pump all the blood out. Now it only pumps 30 ml out. So what is going to happen is that a lot of blood is going to get accumulated into your heart, and that is going to cause a lot of different symptoms. This is the systolic heart failure. And in this heart failure, ejection fraction is reduced. Right. So this is known as heart failure with reduced ejection fraction. Whereas in yes, so the cardiac output and ejection fraction is gonna go down, right? And the stroke volume is gonna go down, the contractility is gonna go down, the left ventricular and diastolic pressure or the preload is gonna increase, right? Okay. Now, secondly, in case of diastolic heart failure or heart failure with preserved ejection fraction, your heart is becoming very stiff. Your heart is so stiff that it says, I'm not accumulating any more blood, right? It won't accumulate any more blood. So just imagine a balloon that you want to put water into it, but the balloon is not expanding. So you're not going to put any more blood into the balloon. So the preload is going to be reduced. When the preload is reduced, the contractility of heart is going to reduce and the heart is not going to pump out a lot of blood. Right? So that is the diastolic heart failure. Right? And there would be increased stiffness of the heart. And in diastolic heart failure, concentric hypertrophy happens. Whereas in case of systolic heart failure, eccentric hypertrophy happens. Right? Okay, welcome. Now, right. So whenever a patient, you think a patient cannot have PCI, if the patient cannot have percutaneous coronary intervention within 120 minutes, then you give the patient fibrinolysis. When you give the patient fibrinolysis, you have to withhold aspirin in that patient, right? And you have to withhold clopidogrel as well. Whereas if you are giving the patient percutaneous coronary intervention, you have to give clopidogrel before starting percutaneous coronary intervention. You have to load the patient with percutaneous coronary clopidogrel. Why? Because there is a condition which is known as stent thrombosis, right? And stent thrombosis is a very, very, very serious and difficult situation. What happens in stent thrombosis is that, so for example, maybe the MI was due to 90% of blockage of the vessel. But what if you enter a stent, if you give a stent to the patient, if you do not give clopidogrel with the stent is gonna close and it is gonna cause 100% occlusion of the coronary vessel. So that is why in order to prevent that, we give clopidogrel to the patient. Now we see the risk of the patient. We see that we estimate that can this patient take clopidogrel for 12 months? If yes, then we give patients drug-eluting stent, which is the better stent. But if the patient cannot take clopidogrel for 12 months, you think that the patient is very irresponsible or the patient has a history of non-compliance, then you give the patient clopidogrel for 1 month along with bare metal stent. Bare metal stent has increased chances of atherosclerosis but decreased chances of stent thrombosis. Whereas drug-eluting stent has less chances of atherosclerosis but increased chances of uh, thrombosis, increased chances of thrombosis, right? So that is it. Okay, guys, so let's keep our discussion till here today. I hope you learned some important things today. And believe me, cardiology was the hardest system, and we are almost done through it. So you have done the most difficult part. So now the easier parts are now left.
Doctor,
Yes, doctor.
can you just summarize the neonatal circulation before pregnancy, during the pregnancy, and after birth, and the problems associated with it?
Yes, so we would do it like so we can do it the day after tomorrow, right? So tomorrow we are going to do the arrhythmias and all of the things, and the day after tomorrow we will do that because it will require like 20 to 25 minutes. Okay.
Okay, thank you.
Thank you. Welcome. Bye bye.